How can we essentially remove part of the liver that is affected by cancer without needing to cut or do any invasive surgery? In this video, I'm going to be talking about radioembolization, also called Y90 treatment. And more specifically, I'll be talking about a procedure called Y90 segmentectomy. And it's one of the most exciting tools that we have to treat cancer, not just because it's effective, but also because it's a way that we can treat or even cure cancer without major surgery. And this is a treatment that can be used for tumors that start in the liver, like a hepatocellular carcinoma, also called HCC, or cholangiocarcinoma, and also for tumors that spread to the liver from other organs like the colon, breast, or lung. Unfortunately, by the time the liver tumors are found, it's often too late to remove with surgery or transplant. And then you're left with immunotherapy or chemotherapy that will treat the cancer, but also will affect all your other organs. That's where Y90 comes in. Instead of giving chemotherapy to the whole body with focused treatment only to the tumor, precisely where it is in the liver. So I know you have a lot of questions like what is it, how it's done, what are the risks and complications, what to expect after the procedure. But don't worry, we're gonna break down to you and go over everything in detail. So Y90 stands for yttrium-90, which is a radioactive isotope that is attached to these like microscopic beads that look like little grains of sand. And these beads can be injected directly into the artery that's feeding the tumor. So once the Y90 is in the cancer, these little beads will release radiation over a very short distance, killing the tumor cells from the inside out, while sparing most of the healthy liver. So how we make sure to spare most of the liver while treating the tumor? You see, the liver is divided into 8 segments. Each segment is supplied by its own artery. With Y90 segmentectomy, we can isolate a segment with cancer and just inject enough radiation to destroy it. Essentially, it mimics a surgical resection, but without an incision. And you will see, over time, the treated segment will shrink and will be absorbed by the body, just like if it was surgically removed. So how is the process and what should you expect? Well, we start with a consultation where we'll review with you your imaging, including CTs, MRIs, ultrasounds, and blood tests. We'll also analyze your whole medical situation and make sure you're fit to undergo this procedure. And the truth is, most patients can tolerate this procedure. The most important part, of course, is making sure that your liver is healthy enough that can tolerate losing a small part. An adult normal liver has a volume of 1,200 to 1,500 mLs on average. And since it's divided in 8 segments, each segment measures anywhere from 100 to 200 mLs in volume. To calculate how much can be treated, we use a term called functional liver reserve, which is essentially the volume of the liver that's going to be available after we do the treatment. And most people need at least 500 mLs of healthy liver to survive. Of course, if your liver is not normal and completely healthy because you have cirrhosis or other medical conditions, you may need more liver than that. And we will take all of that into consideration. After we complete the initial evaluation, in most cases, we plan a mapping procedure. You can think of a mapping procedure as a rehearsal. So in those procedures, we put a catheter in the groin or in the wrist, and under imaging, we navigate this catheter to the artery going to the liver. And when we have the catheter in the liver, we use a fancy imaging that we have in the cath lab called a combine CT, which essentially we can do a 3D volume imaging of your liver. And in the mapping, we can isolate any particular blood vessel that we think it's going to the tumor area and that we're thinking of treating. And we can do a 3D image and in real time calculate the volume of the treatment zone. And based on the volume of the treatment zone, we know how much radiation we need to kill that segment. We even simulate the radiation delivery with an agent called technetium to see if it might go to the lungs or to the GI tract, which help us plan a safe and effective dose for the treatment. Immediately after we complete the angiogram, which is the part that we insert the catheter and inject the dye and measure the volumes, then you go to the nuclear medicine department and you will spend another 15 minutes getting imaging to see where the radiation or the technician that we injected went. Then it comes to step 3, which is the treatment. About 1 to 2 weeks after the mapping, you return for the actual treatment. And at that time, we already know exactly what we're gonna do, so it's usually a shorter procedure. And using the same technique, we insert a little catheter to the groin and navigate to the blood vessel where we already plan to treat and will deliver the radiation. The treatment procedure usually takes 20 to 30 minutes and almost everybody will go home the same day. And what should you expect after the treatment? In the first 1 to 2 days after the procedure, usually people feel pretty good. They did not have the effects of the radiation yet. The main effect of the radiation is fatigue. Many patients tell me that they feel very tired for a week or 2 after the procedure, especially when the doses are very high for usually larger tumors. Some patients tell me they sleep most of the day, and some patients, especially elderly patients, can get really, really tired for 1 to 2 weeks. Pain is not super common with this procedure, but some patients can report right upper quadrant pain, especially if we're using a very high dose to kill tumor. And some patients can have some irritation of the gallbladder after the procedure, although it's pretty rare. Some patients report nausea after the procedure, and if you're experiencing that, you need to let us know, because it usually can be treated with the anti-nausea medication. Serious side effects or complications are very rare, but we do monitor them closely. One of the worst complications would be if you have some of this radioactive material go to the stomach or the GI tract, and that will cause an ulcer that is very difficult to treat. Luckily, these complications are really rare since the imaging is so good in these days, and we have many imaging methods that we use to avoid these complications. Another severe potential complication would be liver failure, and that's when your liver stops working, which can be very serious, and unless you can get a transplant, you could potentially die. This is not very common with Y90 segmentectomy since we're treating only a small part of the normal liver. It used to be more common when we used to treat the entire liver with Y90, which we rarely do these days. Another complication is called radiation-induced liver disease, which is when you don't go into liver failure, but maybe a year or 2 after the procedure, your liver may become stiff and you can develop fluid in the abdomen, or also called ascites. And again, that's not very common with Y90 segmentectomy. We used to see more when we treated the whole liver for obvious reasons. Lastly, another complication is called radiation pneumonitis, and this happens when some of the radiation bypasses the tumor and goes to the lungs, causing a lung injury. The lung is not that weak and can tolerate some radiation up to a dose of 30 gray per session or 50 gray lifetime, and we're very careful with that, and we try to avoid getting even close to those levels. And that's why the mapping procedure is very important, because we use a dose of radiation to mimic and decide how much is the percentage of the radiation that may go to the lungs. Now, to talk about transarterial liver procedures, it's important to understand that the liver is a unique organ. You see, most organs get their blood supply from an artery. For example, the kidney has a blood supply from the renal artery, and then the blood goes through the kidney, and then it drains through a vein, and in the kidney is the renal vein, and most organs are like that. The liver is unique because it gets blood from 2 sources, the portal vein and the hepatic artery. The portal vein is this big vein that drains the blood that is coming from the small intestine. So everything you eat gets absorbed through the small intestine and then goes through the portal vein, gets filtrated in the liver before it reaches the circulation. And the portal vein is responsible for 75% of the blood flow to the liver, whether the hepatic artery is only responsible for 25% of the blood flow. But here's the trick. Normal liver cells rely mostly on the portal vein, while tumors rely on the hepatic artery. And that's why Y90 or even chemoembolization are so effective, as we use the artery to feed the radiation or chemotherapy directly into the tumor while preserving some healthy liver tissue. So how do you know if you're eligible for a Y90 segmentectomy? So if you have liver tumors that can't be surgically removed for some reason, or you don't want to have surgery. You also need to have enough healthy liver left after treatment to support you. And you can't have any serious liver disease or liver failure. For example, we avoid these procedures in patients that have high bilirubin or have ascites. So who are not candidates for Y90? One are patients that have very poor liver function, as we talked before. Two is if we do the mapping and you have a very high lung shunt fraction, let's say 20% of the radiation that we inject will be going to the lungs, then we try to avoid, because we'll never be able to get enough dose in the tumor without giving a big dose to the lungs. And three, patients that have tumor that is widely spread to the liver and very little normal liver left. Most of the chemotherapy throughout these procedures without needing to stop them. There are some exceptions. We prefer to stop medications like Avastin at least a month before the procedure. And that's not only because the Avastin makes the vessels more fragile and you can have more complications, but also it makes sense to stop it because what the Avastin is doing is decreasing the amount of blood vessels going to the tumors. And this treatment works best when the tumors have a lot of blood vessels going to them. And nowadays, there is a lot of data for Y90 segmentectomy. And the data shows it offers similar benefits to liver surgery, but with less recovery time and fewer complications. And no major incision, it's easier for the patient. Studies like the Legacy and the Radiant trials have shown promising outcomes using this approach. And how do we follow up after the procedure? So for most patients, immediately after the procedure, we'll do what's called a PET scan. We don't have to inject you anything else because we already injected the radiation directly to the liver. But the PET scan will show us exactly where we deposited the radiation and while we'll be treated. We can also calculate the dose of radiation that went to that area based on the PET. And I think it's very helpful because in some cases it can show us that we didn't treat the whole tumor and that another treatment is necessary to treat a different blood vessel that may be going to a small part of the tumor that we didn't see before. The findings on the immediate PET, in my opinion, also correlate very well with the outcomes. We then repeat imaging in 1 to 2 months and we already can see some results, although the maximum results will still take 3-4 months to take effect. And we will continue to follow with you as necessary to determine if another treatment may be necessary or not. Many people are concerned if they will be radioactive after the procedure. But the truth is, Y90 emits mostly beta radiation, which only travels a few millimeters. So you're only emitting a very small amount of radiation that's actually scattered, and that won't affect other people. The radiation also fades quickly, and within 4 days, most of it's gone from your body. Can you travel on a plane after the procedure? Yes. Some airport scanners may be triggered for the first few days after the procedure, so just give TSA a heads up. Having said that, we don't recommend you planning any big trips 1 or 2 weeks after the procedure, since we think you're going to be affected in some way with fatigue or pain, and also we want to monitor for any potential complications. I hope this was helpful. Y90 radioembolization is an incredibly powerful and precise treatment. It offers real hope for people facing difficult-to-treat liver cancers without the risks and downtime of the surgery. This is a patient with colon cancer and liver metastasis who was doing well on chemotherapy, but recently had a PET scan which demonstrated 2 new PET-positive lesions in the segments 5, 6 of the liver. He developed these lesions despite being on chemotherapy. And this is when you go do the mapping. Our catheter tip is in the celiac trunk, which is the main trunk that will feed the liver. This is the splenic artery. This is called the common hepatic artery. This is called the proper hepatic artery. And then you have a branch that goes to the left lobe of the liver and a branch that goes to the right lobe of the liver. And then all these small segmental branches, one of each is going to each segment. So which ones are going to segments 5 and 6 in this case? So here's a catheter that was advanced in the right hepatic artery. We identified that it's the branch going to the segment 6, and this one is the branch going to the segment 5. So we do a spin called a cone beam CT, which we can have a 3D image of the blood vessels, and we can in a workstation have a 3D image of all the liver segments. X-ray guidance, we can navigate this tiny catheter into the branch that we want. And this is the branch to the segment 6. Again, we can do a 3D image. And then we can calculate exactly the volume of that segment that we're treating. Here is a 3D picture of the segment of the treatment area. And we can get in real time exactly the calculated volume that we want to treat. But in this case, we also needed to treat the segment 5. And the segment 5 is this branch that is going all the way over here. So we advance our microcatheter in this branch, as you can see it. And we confirm the microcatheter position in this branch to the segment 5. We then do a cone beam CT again to do a 3D volume image and to calculate the volumes like we did before. These are the pictures that we obtained during the mapping, and it's demonstrating where the radiation is actually going. Most of the radiation is going to the liver, specifically mostly going to the tumor areas. And you can see here that very little radiation, you cannot see anything visually going to the lungs. The machine can estimate what's called a shunt fraction. So 98% of the radiation is going to the liver and only a small amount, 2%, is going to the lungs, which is negligible.